Good afternoon and welcome to the American Heart Association's national webinar on moderate aortic stenosis, bridging clinical practice and innovation. Before we begin today, a few quick housekeeping items to note. Today's webinar is being recorded. All participants have been muted upon entry. We encourage an open and conversational discussion, so please engage and share your thoughts. Time has been dedicated at the end of today's webinar for Q&A. Please feel free to submit your questions via the chat at any time throughout the didactic sessions. We will address as many questions as time allows during the dedicated Q&A portion at the end of today's webinar. Please note a recording of today's webinar will be available in the coming weeks as an enduring educational resource on www.heart.org. My name is Deborah Marie Keating, and I serve as a Director of Operations here at the American Heart Association, overseeing our work in clinical studies and novel registries. I would like to take a moment to extend a sincere and special thank you to Cardigan for being a supporter of American Heart Association's Heart Valve Initiative. It is now my pleasure to introduce today's expert speakers. Dr. Srikanth Vemalapalli is an associate professor of medicine and cardiology at Duke University Health System, where he serves as the medical director of the Duke Echo Lab and Cardiac Diagnostic Unit. A member of both the Duke Clinical Research Institute and the Duke Margolis Center for Health Policy, Dr. Vemalapalli is a nationally recognized expert in cardiovascular imaging, implementation science, and pragmatic trial design. His work focuses on improving care delivery and outcomes for patients with structural heart disease through data-driven innovation, health system change, and patient-centered research. Dr. Vemalapalli brings critical expertise in echocardiography and real-world evidence to the national conversation on moderate aortic stenosis. Next, we have Professor Mark Dweck, Chair of Clinical Cardiology at the University of Edinburgh and a British Heart Foundation Senior Clinical Research Fellow. Professor Dweck is an internationally recognized leader in cardiovascular imaging. Professor Dweck's research has advanced the understanding of aortic stenosis pathophysiology and disease progression. His work focuses on identifying novel imaging biomarkers, refining risk stratification, and exploring therapeutic targets in valvular heart disease. As Vice President of the European Association of Cardiovascular Imaging, he is at the forefront of efforts to reshape global paradigms in valve therapy. And finally, we are pleased to have Dr. Brian Linman joining us today. Dr. Linman is an Associate Professor of Medicine and Medical Director of the Structural Heart and Valve Center at Vanderbilt University Medical Center. As an integral member of the heart valve team, Dr. Linman specializes in echocardiography and leads clinical and translational research focused on calcific aortic stenosis. Dr. Linman's research focuses on biomarker discovery, ventricular remodeling, risk prediction, medical therapy targeting aortic stenosis, optimal timing for aortic valve replacement, and other adjunctive interventions to improve patient outcomes. Dr. Linman plays a key leadership role in the Catalyst AV trial, bringing deep insight into evolving therapeutic approaches for moderate AS. Both Dr. Vemalapalli and Dr. Linman serve key roles in the American Heart Association's Target Aortic Stenosis Initiative, a national quality improvement program seeking to advance quality metrics for upstream management of aortic stenosis through their roles on the scientific advisory group and supporting work groups. Thank you to all of our speakers for joining us today. Please note the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The AHA and ASA does not endorse any product or device. Disclosures for Dr. Vemalapalli, Professor Dweck, and Dr. Linman have been listed here as well. Today's webinar and discussion will begin with the burden and treatment needs of moderate aortic stenosis and move through emerging therapeutic approaches like ATA 301. We will explore strategies for expanding research capacity, followed by a panel discussion on real-world implementation and a closing Q&A session. Our goal is to equip you all with both scientific context and practical insights as the space continues to evolve. With that, I would like to turn the mic over to Dr. Vemalapalli, who will help kick things off today. Welcome and thank you, Dr. Vemalapalli.
Thanks, Devin. Next slide. So we want to frame this discussion for you a little bit. And The first step in that is to talk about the unmet need in heart valve disease. So there is actually a fairly high prevalence of heart valve disease amongst patients over the age of 65. This was recently presented at TCT. Nearly 1 in 5 Americans have significant heart valve disease over the age of 65. It turns out there's a lot of undertreatment and delayed treatment for these patients as well. About 50% of all patients with symptomatic severe AS remain untreated and they have delayed or missed treatment. And that, in fact, is related to mortality from a seminal paper by one of our colleagues, Dr. Amaria, a few years ago. On top of that, there are substantial disparities in care where it appears that undertreatment is worse amongst older patients, women, and underrepresented minority populations. Next slide. So here's the data we were referring to actually from Preview Valve, which is just presented a few weeks ago. And you can see the rising prevalence of significant heart valve disease by age, and this is in the US population. And then if you look at the panel on the right, you can actually see the makeup in terms of the type of valve disease amongst those patients. And AS is substantial there at 3.1% amongst the patients over 65 who have moderate or greater disease. Next slide. So just as another piece here, in the Aortic study, which is a community study of patients and including patients below the age of 65, the prevalence of moderate AS, so not just severe, but moderate AS was 0.3% in the population. So oftentimes I think many on this webinar and the general cardiology community will think, well, it's just moderate AS. That's just something to watch and it doesn't really cause any problems. Well, that's probably not true. So this is data from David Playford's group in Australia, where they actually have a countrywide or continent-wide echo database, and they looked at the prevalence of symptoms by severity of AS and then by sex. And if you look at the panel on the left, you can see dyspnea in blue, angina in red, syncope in black. Patients with moderate disease have these symptoms. In fact, 20% of patients between 20 and 30% have dyspnea, despite the fact that they've got moderate AS. You can see, of course, it's higher for severe AS. And again, you see this both in men and in women. Next slide. And what about beyond symptoms? Is there actually a mortality impact in terms of moderate AS? And so again, this is from Jordy Strom in Boston, along with David Playford, and they looked at a multi-continent cohort of patients and plotted their survival curves. And what I want you to take away from this is the black line and the sort of yellow-orange line. The black line is severe AS and the yellow-orange line is moderate AS. On the panel on the left, you can see they're almost overlapped. And that basically indicates that moderate and severe AS have similar mortality. And on the panel on the right, actually, you can't even see that yellow-orange line because it's completely overlapped with the black. So there's substantial mortality as well as symptom burden associated with moderate AS. Next slide. Next. This is again just from the same paper expressing the same data in a different way. This is all one panel, and I'll just point you to the top left portion of the left panel. You can see there, this is the hazard ratio for death. You've got mild AS and then moderate and severe are essentially overlapped. They also looked at a number of other factors, so this puts it in context with other factors such as COPD, chronic kidney disease amongst these patients that had AS. Next slide. And this will become important as we talk about some of the clinical trials that are going on now and have gone on before in this space. But the mortality is different based on LVEF. And you can see where the LVEF is low, less than 40%. Moderate AS has substantial mortality as compared to higher LVEF. So there's a gradation of mortality based on the LVEF. And then on the panel on the right, that's cardiovascular related mortality. Next slide. So we've established there's excess mortality associated with moderate AS, not just severe. There's symptoms associated with moderate AS, dyspnea on exertion primarily. And then there's this concept of trying to prevent cardiac damage, which accrues as the heart has to deal with an obstruction to outflow. Next slide. And when we think about this, these concepts have informed several trials which are either finished or ongoing in this space. So first, we'll start with the TAVR Unload trial. And that was a trial that's been finished, and it was designed as a prospective randomized trial examining the efficacy of TAVR versus clinical surveillance in patients with moderate AS and heart failure with reduced ejection fraction who are on optimal medical therapy. Patients were randomized 1-to-1 for transfemoral balloon expandable TAVR versus clinical surveillance. Next slide. And I just want to point out a few things here. The endpoint was what we call a hierarchical endpoint. So they kind of compared each of the components of the endpoint between the two strategies. In the blue, you can see TAVR, and on the left-hand side, you see the longest follow-up for each patient. On the right-hand side, just the 1-year follow-up. If we focus just on the 1-year follow-up, what they're doing here is comparing wins, which strategy wins. So if you look at the all-cause death, there was 12.9% of the cases TAVR wins, meaning TAVR is better, versus clinical surveillance at 7.4%. And as you go down, you can see stroke is about equal. Hospitalization, TAVR wins over clinical surveillance. KCCQ, TAVR wins, so that's quality of life over clinical surveillance. And you can see overall, when you put it all together, TAVR appears to win numerically 48% versus 30.9%. Now, if we actually advance to the next slide, you'll see this is actually a neutral trial because it was underpowered. And there were some questions about medical therapy in the group. But looking at each component, TAVR appeared to be better, although it was underpowered. So moving on to the next trial, this is the progress trial. This is ongoing, but here's the design. This is basically moderate AS patients who either have ventricular dysfunction or cardiac damage and who are candidates for transfemoral TAVR. They're randomized to TAVR versus clinical surveillance. And you can see the primary endpoint. It'll be a composite of death and heart failure hospitalization at 2 years. And there'll be a safety composite, including death, stroke, and life-threatening bleeding at 30 days. So this is ongoing. We're expecting the results relatively soon, but this will help to answer the role of TAVR in select patients with moderate AS. Next slide. And then finally, before turning this over, I will end with the Catalyst AV trial. And here's the design. This is looking at a medical therapy called atacicept. And this is, again, amongst patients with moderate AS. The patients will be randomized to atacicept versus placebo. And the primary endpoints are change in aortic valve calcium and peak VO2. So for those who are unfamiliar, this is a metric of exercise capacity, which is often derived from a cardiac exercise testing. And then we'll also look at rate of aortic valve area decline and a safety of composite of adverse events at 2 years. So really the key here is looking at valve calcium and peak VO2. And so this is going to uniquely target physical dysfunction related to moderate AS. Next slide. So in conclusion, moderate AS is associated with dyspnea. It's also associated with increased mortality, similar to severe AS. TAVR Unload showed improved quality of life, and it looked like improvements on some of the other parts of the endpoint, but it was underpowered, and so it was neutral. The Progress trial will investigate the role of TAVR in moderate AS with cardiac damage or dysfunction, and the Catalyst AV trial will evaluate whether atacicept slows progression and of valve calcification and investigate symptoms of moderate AS by measuring functional capacity. And with that, I will turn it over to our next speaker, Dr. Dweck.
Okay, thank you very much, Shrikit, and it's a great pleasure to be here. My talk is really going to focus about the need for a medical therapy in these patients with moderate aortic stenosis, why we think this would be a good idea for us to try and develop. I have the following disclosures, which have been shown before. So this slide, I guess, gives a European perspective to what Shrika has already told us, which is that aortic stenosis is already a very common condition. We see a lot of patients already in our clinics with this condition, and with an aging population, that prevalence is set to triple by 2050. And so if it's already a problem, then in 10, 20, 30 years' time, we're going to see a huge number of these patients, and we need to come up with good treatment strategies to try and help them. Next slide, please. And it's also one of the most prevalent and important cardiovascular conditions that's left that doesn't have an effective medical therapy. So most of the patients that we see coming through cardiology units, we've got very good treatments for. We've got very good tablets that can alter the natural history of the disease, that can prevent adverse events down the line. But aortic stenosis is an important exception to that rule, and there is a need to develop medical therapies that slow the disease. As we've heard, we have clever techniques that can replace the valve surgically or percutaneously. But really, if we can develop a medical therapy that stops the disease from progressing, then potentially we can do without the need for such invasive treatments. And so frequently the patients that we see in the clinic are frustrated by this lack of a medical therapy. They don't quite understand why we're not doing anything to their valve. We're just simply watching it, seeing it progress over time and not intervening. And I think clinicians are also frustrated at the fact that we can't really do anything to modulate this disease. The other important thing is that because we don't have a medical therapy, there is a large and growing market of patients that potentially would benefit from a treatment if we can develop one. And so this is, I think, getting through to pharmaceutical companies who understand that this is an important condition to focus upon, to try and develop new treatments, because they're liable to be used by a lot of people and benefit a lot of people. So it's quite an exciting time in the area. We have at least 2 large pharma-driven studies, and so a lot of us are hopeful that the next era of this disease will be one where medical therapy starts to become used in patients. Next slide. So those are all the reasons why you might want to do trials to kind of develop a new therapy, but these are some of the reasons why you might choose that's not a good idea, and that's because all the trials that have been done to date have been neutral, and some of these are from our group in Edinburgh, so we have bitter experience in this area, and this is not an easy thing to do. If it was an easy problem to solve, we would have done it by now. But developing a medical therapy for aortic stenosis is a challenge, and one that has led to several trials that haven't proved effective. Next slide, please. So the rest of the talk talks a little bit about the disease and how we might try and design trials, and how the sort of targets we might go for in people with moderate aortic stenosis. So, of course, aortic stenosis is characterized by progressive narrowing of the aortic valve. You can see it on these images. The valve is struggling to open, and of course that means that the heart muscle has to work extra hard to try and pump the blood out through the tiny narrowing that is the aortic valve when it's stenotic. And so it places a big burden upon the heart muscle. And ultimately, when we consider the sort of things that lead to patient having symptoms or adverse events, then that's as much to do with what's happening in the heart muscle as it is what's happening in the heart valve. And I guess that's quite a good story in terms of drug development, because both the valve and the myocardium are good targets for developing new treatments that can potentially help patients with aortic stenosis. And there are trials ongoing that target both these areas. And we're going to talk about the valve and then the myocardium in sequence. Next slide, please. So firstly, the valve. Next slide. This is a summary, a complex summary of what we understand by the pathogenesis of aortic stenosis. And it is complicated, but as you can see, it is an active process. There are very many similarities to atherosclerosis, but also key differences. And the major difference is that really in the sort of middle to end stage of the disease, this is a disease of fibrosis and progressive calcification of the valve that's driving the stiffness and stenosis. But as we look at these pathways, these are all potential areas that we could target with novel medical therapies. Next slide. So those are some of the things we could target. What about how we might design these trials? So next slide. So obviously, in most studies, you want to go straight to a clinical outcome trial because that's a way of demonstrating that the drug actually has a meaningful impact on patient outcomes and a good way to get approval for your drug. The problem is trying to do these trials in aortic stenosis is difficult because it takes a very long time for patients to accrue the events that you might want to look at. And so the trials are very expensive and often very large. And given the problems with previous trials, not many pharma companies want to jump straight into a clinical outcome trial. So as an alternative, most trials are now looking at phase 2 clinical trials, where basically we're trying to demonstrate that a given drug slows the progression of the disease. So if you can slow aortic stenosis from progressing or stop it from progressing, then patients aren't going to reach severe aortic stenosis and the need for aortic valve replacement. So the link between disease progression and these clinical outcomes is very close, and phase 2 clinical trials make sense as a bridge, if you like, before you do the bigger phase 3 trial. Next slide, please. And so how can we look at disease progression in aortic stenosis? Well, there are different imaging modalities that we can turn to. Principally, we need to think about two techniques. The first is echocardiography. This is the ultrasound technique we use every day in the clinics to measure aortic stenosis severity, to monitor its progression. And so, of course, most trials want to demonstrate that you can slow progression on echocardiography. But echocardiography lacks some precision. And so often, if we're doing a trial with that, we need very large numbers of patients to show an effect. So an alternative is to use CT imaging of the valve, where we can measure basically how much calcium there is in the valve. We can do that more precisely. We need fewer patients to demonstrate an effect. And so often you'll see many of these trials look at both echocardiography and CT calcium scoring, the progression of those two things to see if the drugs are working. And if the drugs are slowing progression on echo and CT calcium scoring, then that's a good sign that they're likely to be effective in clinical outcome trials. We can also look at more advanced imaging, but that's, I guess, areas of research rather than things that people are really focusing on in these trials. Next slide. And so how have these techniques been used? Well, next slide. This is a trial that we did in Edinburgh. It was called SALT-R2. We thought we'd use osteoporosis agents to try and slow aortic stenosis. It was one of these phase 2 trials. We basically used imaging to see whether these drugs had an effect on aortic stenosis progression. And like most trials that are ongoing, we looked at echocardiography and CT calcium scoring as our primary endpoint. We threw PET in there as well as a kind of earlier assessment. Next slide. So unfortunately, the slide was completely neutral. The trial was completely neutral. Our drugs had no effect on aortic stenosis progression, but all of our different modalities showed the same thing. So there was consistency across the different techniques. There was no effect on calcium scoring, echo, or PET imaging. So this was obviously a kind of crushing finding when you've spent all this time doing this trial. But I think it has proved useful in that it's created a template for how other trials are now looking at new drugs and whether new drugs might have more effect in terms of aortic stenosis progression. And so a lot of the trials that are ongoing have a similar kind of design, looking at echo and CT calcium scoring, often as co-primary endpoints. Next slide. So that's the valve. What about the myocardium? So as I said, the myocardium is another target for the development of medical therapies, and in some ways an easier target because we already have a lot of good treatments that we can use for patients with heart muscle disease, and in particular for patients with heart failure. Next slide. And if we look at what's happening in the heart muscle, then essentially what happens is that the valve has to pump against this narrowing, the heart muscle becomes thicker, and that's a good thing because it then is able to pump through the narrowed valve. But with time, the thick muscle outgrows its heart supply, and the heart muscle starts to scar up, and the heart muscle cells start to die, and that drives this transition to heart failure and adverse events. So this, if you look at this to kind of take a step back, this slide looks quite a lot like HFpEF, so heart failure with preserved ejection fraction. And so many of the targets that we're trying to treat in HFpEF populations are also there in patients with aortic stenosis, things like myocardial fibrosis, left ventricular hypertrophy, impaired relaxation of the heart. And so it makes some sense that we might want to try and use heart failure with heart failure medications also in aortic stenosis. Next slide, please. Next slide, please. And also what's interesting is that if you look at the early intervention trials that we've just heard about in people that have severe asymptomatic aortic stenosis, what we found pretty consistently across all the trials was that if you intervene earlier, you leave people with less heart failure following their valve intervention. And so that's important in terms of the timing of aortic valve intervention. But it also tells us that the heart failure that patients with aortic stenosis commonly experience is potentially modifiable. And so we can modify it potentially with the timing of intervention, but also we could potentially modify it and prevent it by using heart failure medication. Next slide, rather. And this is the next trial on the next slide, which is designed for the sort of study that you could do in the myocardium, where we're using, in this study, heart failure medications, and we're seeing if we can improve myocardial health using these heart failure medications in our patients with aortic stenosis. And what's kind of interesting and cool about this is that we're trying to prevent heart failure. This is not really about treating heart failure, because they don't have the syndrome of that often yet, but this is heart failure prevention, which is, I think, quite an interesting area. Next slide. So in conclusion, I think aortic stenosis is an important condition. It's a growing condition. It's one of the last conditions where we don't have an effective medical therapy, and we need to develop one. The sooner, the better. Our patients want to do that, us to do that, and as we understand the disease better, then I think we're getting closer to actually getting the first medical therapy. We have two targets. We have the valve, and we also have the myocardium, and there are lots of trials ongoing aiming at developing these treatments that I think will be of major benefit to patients with this condition. Thank you very much for your attention.
Thank you, Professor Dweck. And next we have Dr. Brian Lehman, who is going to be sharing the need for medical therapy in valve disease and the role of ATA 301. So thank you and welcome, Dr. Lehman.
Terrific, thanks. Can you hear me okay?
Yes, we can.
Great. Well, first, I'll just have a couple slides to, you can go to the next slide. Just the mental model that I have in mind, really reinforcing what's been said by and this is that as the aortic valve progressively narrows from mild to severe aortic stenosis, the pressure overload that occurs on the ventricle leads to maladaptive remodeling in terms of hypertrophy and fibrosis, and eventually diastolic and systolic dysfunction. When exactly that occurs, that is, what valve area that remodeling and dysfunction occurs varies from patient to patient. So some patients with a valve area of 1.2 may have very little of this, whereas others it might be excessive. So this does vary. The maladaptive remodeling and dysfunction sets patients up for a residual risk related to heart failure after valve replacement. And so I think it's helpful to think about aortic stenosis as a precipitant of and precursor to heart failure. And so many of the interventions that Mark was just mentioning in terms of targeting the myocardium could be helpful to prevent that. You could advance. And then also after the valve is replaced, to think about mitigating heart failure that may have been the precipitant for valve replacement with medical therapies targeting the myocardium. So you could advance now. So there's an opportunity to potentially intervene earlier. We heard about some of the trials that are testing that before symptoms occur or before AS is even severe. You could advance. Or an opportunity for medical therapy targeting the valve or the ventricle to slow the progression of valve narrowing or to slow the adverse effects on the myocardium. And then finally, after you could advance after the valve is replaced, medical therapy to augment reverse remodeling and recovery. So this is the mental model I have in my mind as I think about these issues. Next slide, please. So this is an overview, at least from my perspective, as we think about aortic stenosis, even progressing from sclerosis across the spectrum of mild, early moderate, late moderate, undergoing valve replacement, the opportunities and how large they are for targeting the valve and the ventricle. And so, at least from my vantage point, the biggest opportunity to target the valve is really between a valve area 1.3 to 2.0, probably. The late moderate is an area where we're going to learn about, and it may be that select patients may benefit from earlier valve replacement. Those trials will report out soon, and maybe they won't. And even if they do, there will be a number of patients in the late moderate stage who haven't had as much of the maladaptive remodeling or the symptom onset that may still benefit from medical therapy targeting the valve. And then also, as Mark alluded to, an opportunity to target the ventricle as well. Next slide, please. And next slide. So here in the next few slides, I'm going to give an overview of Itacigoat and sort of the rationale. I won't spend too long on this. Mark gave sort of a mechanistic biology slide, and this is pointing to the initiation and the progression events that lead to the fibrocalcific pathobiology in the valve leaflets. And we can see how relevant to Itacigoat soluble guanylate cyclase often becomes oxidized in calcific aortic valve disease, and this leads to an upregulation of pathways leading to calcification. Next slide. These are just a few papers and data linking the amount of calcification in the leaflets, both to diastolic and systolic dysfunction, and greater amounts of valve calcium in the leaflets, leading to a greater incidence and onset of heart failure over time. Next slide, please. And this is showing that even stronger than valve area and transvalvular gradient valve calcification is independently linked to valve replacement and death. Next slide, please. So with respect to Itacigoat, I mentioned that the soluble guanylate cyclase can become oxidized, and Itacigoat is able to activate soluble guanylate cyclase and has a particular affinity for the oxidized form of soluble guanylate cyclase, which also helps to minimize the off-target or systemic effects and some of the hypotension that you may see with other molecules affecting soluble guanylate cyclase activity. Here on the right, you can see some of the preclinical data in mouse models of aortic stenosis showing that Itacigoat reduces the formation of aortic calcification in the leaflets. And then on the right, data from a small phase 2 clinical study wherein patients who were given Itacigoat over 6 months had slower progression of aortic valve calcium on CT. Next slide, please. So the summary of the clinical experience with Itacigoat to date, Itacigoat has been used actually in a number of clinical studies with upwards of 1,000 patients who have received the drug and shown a very favorable safety profile and minimal to no effect on blood pressure. And in patients specifically with aortic stenosis and studies done at Mayo Clinic, the phase 1b study showed that there was no impact on blood pressure in patients with mild or moderate AS. And then in phase 2, a reduction in aortic valve calcium when given over 6 months. Next slide, please. So these are a few of the data from that phase 2 study, which included 23 patients, so it is small, randomizing them to placebo or tasigwat for 6 months. And here you can see that there was a reduction in the progression of aortic valve calcification and a strong trend towards a slowing of the narrowing of the aortic valve area as measured by the continuity equation. There did not seem to be an effect on transvalvular gradients or velocity as shown on the right. Next slide, please. With respect to myocardial or LV function, you can see that atacicept was associated with a increase or a better LVEF at 6 months compared to placebo, with a trend towards a greater increase in cardiac output at 6 months. Next slide, please. With respect to parameters of diastolic dysfunction, atacicept was associated with a trend towards less of an increase in E over E prime, which is sometimes a surrogate of LV filling pressures. And here you can see a statistically significant association between the change in E over E prime and the change in aortic valve calcium, so that those who had a greater increase in valve calcium, which tended to occur more commonly with placebo-treated patients, there was a greater increase in E over E prime. Next slide, please. So relevant to one of the endpoints in the CATALYST trial, there are data in non-AS populations showing a relationship between peak VO2 and E over E prime. That is, those with a higher E over E prime have less peak exercise capacity, so a lower peak VO2. And then what I just showed you in the phase 2 study with atacicept, that those who had more increase in valve calcium had a greater increase in E over E prime. So here there's at least the possibility that valve calcium has an impact on E over E prime, and based on prior data, a relationship between E over E prime and peak VO2. So whether that plays out in the context of this trial, treating people with atacicept, where it would be hypothesized that a slowing of aortic valve calcification may lead to a difference in peak VO2, such that those who have more aortic valve calcium over time, hypothesized to be in the placebo group, would have worse peak VO2 over time. And then some additional endpoints that'll be looked at. Next slide. So just at a high level here, the thought process is that change in aortic valve calcium impacts the function of the aortic valve leaflets, both the area, the orifice opening, and also perhaps the compliance of those leaflets, and that has effects then on cardiac structure and function, and that may also then have effects on symptom onset or severity and cardiopulmonary function as measured by maximal exercise. Next slide. So the CATALYST AV trial is a phase 3 two-part study. You can advance to the next slide, or the animation here. So the questions are: what is the effect of atacicept on slowing progression of aortic valve calcium? That's the fundamental question. If it does not affect aortic valve calcium, sort of the rest of it almost doesn't matter. How does the change in aortic valve calcium correlate with echo measures of diastolic function and LV remodeling along the way? Next slide, or advance. And then how do these changes relate to symptom onset or severity and cardiopulmonary function by exercise? And then and assessing this with a peak VO2. Next slide. So this is a schematic to outline the trial, a little bit more detail than what Shriek had introduced earlier. So you see on the left the inclusion criteria for the study: patients over 50 with moderate AS with a reasonable amount of calcium, because the impact is supposed to be on calcium accrual. And patients are randomized to a Tasigwat or placebo. And you can see part A, which will be assessed, I think, after 266 patients are enrolled. The primary endpoint will be looking at aortic valve calcium, but also exploring whether or not there's a relationship between AVC and peak VO2. And then part B, with a little longer follow-up, will be looking at the change in peak VO2 and aortic valve area. And then additionally, looking at clinical composite endpoints such as progression to severe AS, need for valve replacement, death, etc. Next slide. And okay, that's
Thank
it.
you, Dr. Lindman. And next, we welcome back Dr. Vemalapalli, who will be sharing insights into the expanding research capacity for medical therapy in moderate AS. Welcome back, Dr. Vemalapalli, and thank you, Dr. Lindman.
Thanks, Devin. I think, we've heard some compelling information about why moderate AS is important. We've heard from Mark some of the thoughts in terms of trials that have been done in the space, trials that are being done in the space, and some of the pathophysiology for why certain medical therapies might be useful. The question is, how do we translate that to actually doing research in the moderate AS space? So we're going to talk a little bit about that translation piece, given that the field has been historically dominated, at least in the recent history, by trials of devices, interventions. And then how might we use registries or other real-world data sources to actually feed these trials and try to advance the science in the area? And we might even be able to use ongoing QI processes such as Target AS to build that research capacity. Next slide. So again, this is a kind of a little bit of a rehash of a slide you saw earlier. The roles for medical therapy, just very broadly speaking, might be before you get to the point of needing an aortic valve replacement. And we heard a little bit about Tasigwat there. There are also ongoing trials for Lp(a), which you may have seen in earlier slides, is one of the risk factors for valve calcification. And then we've alluded to a little bit this idea of patients, because of cardiac damage, which was sustained during the lead up to developing severe AS, having ongoing heart failure after having a valve replacement. And so there's actually data now to support the use of SGLT2s in these patients, as well as ACE inhibitors and ARBs. Next slide. So as we mentioned earlier, there are a number of trials in the moderate AS space that are ongoing at different stages. And I just wanted to include this slide here to compare and contrast them a little bit. So we can see a progress in Expand TAVR 2. These are predominantly interventional studies, age over 65, Catalyst AV, much lower age. You can see the differences in terms of how they define moderate AS, similar but slightly different in terms of details around whether valve gradients are used or just valve areas. And then a really important part of this is whether the patients have symptoms or signs of cardiac damage. And you can see Catalyst AV in terms of the EF, and then Expand TAVR and Progress, how they've approached this. And again, the exclusion criteria are varied given the type of intervention that's being studied. So there are some differences amongst these trials. Next slide. Now, to get to this question that I posed earlier, you can advance all the way through this slide. We have traditionally seen trials in this space dominated by interventions and by devices. And I just want to point out that the way you would put such a trial into practice, or recruiting for such a trial into practice at a site, is very different for severe AS or an interventional trial versus a medical therapy trial. And you can look at this schematic, which tries to recreate the pathway of clinical care for patients with AS. So there's a primary care or a cardiologist seeing the patient. They have a symptom or a sign and end up getting an echo. And then if that echo shows severe AS, hopefully that patient gets referred to the heart valve team. And it's at that point, oftentimes, that clinical trials are considered for these patients, especially those with severe AS or where an interventional device is being considered. But if we're talking about moderate AS, the current clinical pathway, of course, says, okay, that patient doesn't need a valve replacement right now. So I am going to send that patient back to their primary care or their general cardiologist, who I hope will follow up on that aortic stenosis and do a repeat echocardiography at a given time frame until the patient becomes severe. So if we're looking to improve the quality of care or recruit patients for clinical trials with moderate AS, we really need to focus upstream of the heart valve team. And I'm going to make some argument to you here in the ensuing slides that we need to focus in the echo lab to find these patients. Next slide. So go ahead and advance through this. This is a figure from a paper that Dr. Lindman was the senior author on that is in press now at Journal of American College of Cardiology, and it's an expert consensus statement. And it has many things in it, but I just want to point out what's at the bottom. Advance. This is about moderate AS. So really, we hope that perhaps in the future the heart valve team will take on the burden or the responsibility for caring for patients even with moderate AS and arranging their clinical surveillance and considering them for trials of either early AVR or medical therapy. But at the moment, that's not what's happening in the majority of places. But this expert consensus statement does acknowledge that there are clinical trials here and there's a role for trying to recruit these patients into those trials. Next slide. So how might we do that? How do we identify these patients? Well, here's some things that are often used when you're trying to find patients in a clinical trial. Sometimes maybe we'll do ICD-10 coding. As we know, especially for non-severe aortic stenosis, this has a really low sensitivity and is probably not a great way to find these patients. Maybe you'll use an echo database. You can query that database and find all the patients with moderate AS in a particular site and say, okay, maybe some of these patients need to be evaluated for research opportunities. Well, maybe not every site has the ability to query their own echo database. And so there are tools out there, AI-based tools now, that use natural language processing to go through echo reports and try and find these types of patients. So that might be an opportunity. And then I'll point out that many sites in the United States participate in various types of quality registries. I've listed some of them here, the Society of Thoracic Surgeons, the TVT registry, both of which really focus on patients who are getting valve replacement. But then I'll point out Target AS because Target AS is really focused on quality improvement up into the point of valve replacement, certainly beyond as well, but especially focusing on up into the point of valve replacement. And so that might be an opportunity to identify patients who not only need quality improvement in terms of their care, but also who may be eligible for research in this space. Next slide. So I just want to make a kind of a concrete example out of that. So go ahead and yeah, perfect. So here we've taken some of the inclusion and exclusion criteria for the Catalyst AV trial. And then in the columns on the right, I've just said, might you find this information in, say, an echo database or perhaps in Target AS if your site participates? And you can see aortic valve calcium scores. Yeah, I probably wouldn't expect to find that in an echo database, but it is captured in Target AS. Now, we'll come back perhaps in our discussion point to talk a little bit about cardiopulmonary exercise testing. But as of now, that's something that's not found in either place. And then I'll just point out again, in terms of the exclusion criteria, there are a lot of no's here under the echo database port column and fewer no's in the Target AS column, suggesting that this type of a quality registry might be very helpful in trying to screen patients who might benefit from research opportunities. Next slide. So, I think there are equal challenges both in the clinical care of these patients with moderate AS and in identifying them for research opportunities. The graph on the right is from a paper that's at this point almost 8 years old, which basically shows how long it takes for a patient with, in this case, mitral regurgitation, to get the guideline recommended follow-up imaging. And, for moderate mitral regurgitation, it should be a 1 to 2 year time frame to get follow-up. You can look at these values here. Most of these values are pretty high. We've got some that are at 2.5 years, and this is broken down by specialty. The main thrust of this paper is the majority of patients are not getting the type of follow-up they need. And that's in part because there's no real system to ensure this. And this is what QI efforts such as Target AS are trying to help build, is a system to actually find these patients, ensure they're getting clinical care. And then for our purposes in this discussion today, that same system could be used to help identify these patients for research opportunities. Next slide. So going back to this, I'll just point out to the similar point I showed you MR before. You'll look to see here from the time that a patient with an echo and severe AS gets their AVR is 160 days, again reflecting the fact that the system is not well built. That's longer than one would want. Next slide. This is a really, really important document. Again, I promised you I would make the argument that the Echo Lab might become the center for actual both clinical care and research opportunities for patients with moderate AS. And this document is part of the way that's going to happen. This was published in September of 2025. It's from the American Society of Echocardiography, and it's standards for echocardiographic reporting. And I'll just point out a couple of very important points. The following language was placed in that document, and what it does is basically make a clinical recommendation about care, in this particular case, for patients with severe AS or significant AS, which might be in the future, depending on these clinical trials, expanded to include moderate AS. And this, plus the fact that we should be giving recommendations on follow-up imaging, is really beginning to enter into the guidelines from the ASE and perhaps in the future, even into accreditation. And this really corresponds with what Dr. Lindman has in his expert consensus document, which is eventually we want the heart valve team to take on lifetime management, proactive surveillance, strategy, and timing, not just for severe AS, but perhaps for moderate AS as well. But until that happens, it's really the Echo Lab that's going to be driving care for these patients and research opportunities. Next slide. So in conclusion, moderate AS, certainly an emerging frontier in valvular heart disease. There are medical therapies here and potential device therapies. QI registries such as Target AS and perhaps even EchoLab databases can be used not only to drive the clinical care of these patients, but also to identify these patients who might benefit from research opportunities, such as the trials that you've heard about today. And because of the way the guidelines are going and because of the way that clinical care is delivered for patients with moderate AS, it really is going to be the Echo Lab, the non-invasive imagers who have the opportunity to build the system that's necessary to expand research for those patients with moderate AS.
Thank you,
Thanks.
Dr. Vemalapalli. And now I'd like to welcome all three of our speakers back to use our remaining time today for a panel discussion on real-world considerations and clinical implementation. So we can just advance to the next slide and welcome back Dr. Brian Lemon and Professor Mark Dweck.
Perfect. Thanks, Devin. And certainly if there are questions, from the audience, please put them into the chat and we'll try to address those during our discussion. But Brian, maybe I'll start with you. We've talked a lot about medical therapy in this moderate AS population, and we've, I think, made the argument that there's cardiac damage while the valve is getting calcified. Can you kind of just try to put those concepts together? Why do patients potentially have heart failure when they wait too long, or they get AVR at a later time? Why might earlier intervention, whether that be medical therapy or potentially AVR, be helpful?
Yeah. Well, I think that the fundamental underlying issue is that the narrowed valve causes pressure overload on the ventricle, which causes maladaptive remodeling and dysfunction, which is the setup for and the precursor to heart failure. That's sort of across the field. It's not just AS. I mean, hypertension, other precipitants, same pathway. Um, and there's heterogeneity in terms of when patients develop that, and a variety of factors that influence it. There are concomitant hypertension, coronary disease, diabetes, obesity, sex, genetics, etc. So these lay the groundwork for heart failure. Some people, it occurs earlier in the moderate stage. Mark's shown a lot of studies showing fibrosis even begins in the mild stage. And so these things are happening. And so, there might be a group of patients for whom maybe earlier valve intervention would, yield better outcomes, reduced heart failure, reduced death. For others, and the details will matter, it might be medical therapy, maybe trying to prevent those things or at least slowing their development, which lay the groundwork for heart failure. So to try to mitigate that.
I think those are key points, Brian. And maybe one piece that I'll add to it is I think sometimes we think of AVR as the panacea, that once we do the AVR, all that cardiac damage that's occurred beforehand is going to go away or it's going to reverse. And you've been one of several who have shown that that's not always the case. Mark, I want to come to you. You've been a luminary in sort of thinking about non-invasive imaging to try and find those patients who have fibrosis and damage, and perhaps, whether it's medically or by AVR, intervene earlier. What about this concept of CPET? Like, how do you think about that in your mind as a functional way of assessing for damage versus kind of non-invasive imaging?
Yeah, I mean, that's a good question. I think the great advantage of CPET is that it much more closely reflects patient symptoms, right? And in medicine, we try and make people feel better. We try and make people do better in terms of prognosis, avoiding events. So I like the idea of CPET as a way of as a surrogate of patient symptoms. And we all want and hope that the novel interventions can make people feel better, and maybe CPET as a way of us measuring their ability to do that. And so I think that's an interesting thing to look at. It's probably an under-researched area in aortic stenosis. We don't have, I think it's fair to say, an absolutely clear handle of what that technology can really do in this condition. But I think it's exciting to see it in new trials and so we can understand it better. And with all these things, I think that one of the things with aortic stenosis that is a key issue is that, of course, they have the valve disease, and we've talked about the myocardium, but these are elderly people often, and they have lots of comorbidities. And so, one of the big challenges is always teasing out what is due to the valve and what is due to all the comorbidities. And that's something that I think we need to try and do better at, and something where potentially advanced imaging, advanced assessments can help. But yeah, the way we're going to answer these questions is ultimately the randomized controlled trials, and that's going to lead us to the truth. And it's really exciting we have all these trials ongoing.
All right, that was great. I think this idea of trying to understand what the utility of CPET is in these patient populations, maybe even correlating it not just to patient-reported symptoms, but to what we already know via non-invasive imaging might be useful. Brian, I know we're short on time. I just wanted to ask you one question here. If you were trying to expose patients with moderate AS to research opportunities, at Vanderbilt, and you've done a lot of clinical trials there. What would be one or two things that you would do to try and identify and approach these type of patients?
To identify them for reaching out, yeah.
Yeah.
I mean, at our system, we've utilized Tempus, and that allows us to survey our whole ecosystem and also marry that with some of the inclusion exclusion criteria of the trial to provide a filtered list of who actually might be candidates for a certain trial of interest. And you could even marry that with automated reach out messages, potentially to patients and clinicians. So I think we need some structured ways of surveying our echo databases, perhaps using tools like Tempus, Ignite, others to do that. But that's I think, the scalable and most efficient way to go about it.
Thank you so much, Devin. I know we're at the top of the hour. I'll turn it back over to you.
Yes, and that marries nicely with the question that was in the chat. So I hope that answers that question directly of standardizing echocardiogram reports, so to be able to facilitate earlier valve evaluation. So great segue. If we can advance just one more slide, two more slides there. Just before we wrap up, we just have a call to action for all attendees on today's webinar, and any of your colleagues in this space as well. We'd appreciate if you take 5 to 10 minutes of your time to complete a brief survey on moderate aortic stenosis practice patterns and current clinical climate. Your insights are going to help us understand how moderate AS is identified and managed, assess readiness for medical therapy trials, and shape future outreach and engagement. The survey should only take about 5 to 10 minutes of your time. It is anonymous unless you choose to opt in to share your contact information to receive more information and resources. But we aim to use these survey findings to directly inform efforts to improve care delivery, strengthen research readiness, and expand trial access for patients with moderate AS. So either scan the QR code here to complete the survey. We'll also pop that link in the chat, and we'll be sure to email the survey link out to all attendees after today's webinar. But first and foremost, would like to thank you all for your time, your support, and your interest. And encourage everyone to complete the survey, and would also like to send a special thank you to Dr. Vemalapalli, Professor Dweck, and Dr. Lindman for your expert insights today, and to Cardigan as well for supporting this initiative. Thank you all so much. Have a wonderful day. Recordings of